Good evening. Am I audible to you and am I visible to you?
Yes, you're audible and also visible.
Not visible.
Yeah, you're audible and also visible, so both.
Okay,
Both
okay,
are
okay.
possible.
Right. Okay. Only very few students have joined, so we'll wait for about 4 or 5 minutes. Anybody ready with the case? Anybody ready with the case? Anybody who has come with a case, then we can present that case, or otherwise I have come with some spotters so that we can discuss a few spotters, about 32 spotters. Nowadays in the examination there are plenty of spotters are shown, and that will help you in the examination also. Okay, we shall start the program. So anybody who has come with a prepared case, if nobody has come with a case, we will start with a spotter session. Okay, so we'll have a spotter session. Okay, anybody can answer? Okay, what does this show? These are all symbols you must be doing regularly. So there should not be any difficulty for you to diagnose and also to discuss what should be the correct management. Anybody, somebody is the final year DM DNB student can answer. Dr. Bensi, would you like to try? Bensi?
No, sir, I'm first year, sir.
Oh, you're first year. All right. Where are you joining? Where are you undergoing training?
The Kim's Trivandrum.
Kim's Trivandrum. Okay, right. Okay. Okay, Saroj, would you like to give a comment? Obviously, this is very straightforward, but not difficult at all.
So CAG in cranial view.
Oh,
So it is showing that 1 minute. So distal LMCA is significantly diseased.
yes, almost 90% stenosis.
Yes, sir.
Starting from the mid LMCA, extending up to the bifurcation. Okay, right. Yes. And is the lesion extending into the branches?
Yes, sir.
Also?
Yes, sir. Yes, sir. So,
Yes,
lesions are, yes, sir. It is extending into the, sir, ostium of the sarc is diseased. And sir, LAD, sir, not, sir, LAD may be, sir, ostium, but, sir, I think we will take the caudal view, then we will understand better regarding.
Yeah, but this view itself, there is a suspicion or maybe evidence that left sarcostem is definitely involved, and also the LAD.
LAD distal, not ostium, but sir, proximal part of the LAD is significantly diseased. And sir, D2 is also from the ostium diseased.
Yes.
That is very large artery also, though caliber is not so much significant, but sir, it is supplying large territory.
Yes, I think it's a relatively big vessel, and if you look at the size of the
maybe dual LAD types.
Diagonal, it is almost as big as the LED. It is area of supply also is very very significant. Okay, yes. How do you make out? See, what are the areas in which coronary arteries are there in the heart? Which are the areas in which coronary the epicardial coronary arteries are seen?
Sir, left circumflex is in the AV groove. Posteriorly.
Seen in the atrioventricular groove. Let's focus on the atrioventricular groove, and the right coronary artery is in the right atrioventricular groove.
Right atrioventricular groove. And sir, LAD, sir, interventricular groove.
Yes, LAD is in the anterior interventricular groove and may wind round the apex and enter the posterior interventricular groove. What is the other artery in the posterior interventricular groove?
Posterior interventricular groove.
Anybody? Which is the other artery which is in the posterior interventricular groove?
Sir, posterior interventricular groove, sir.
Yeah.
So that will be, sir.
Yes.
PDA, sir.
PDA, posterior descending arteries in the posterior interventricular groove, and the branches of these main arteries are on the surface of the ventricles. They are on the surface of the ventricles. Okay. By looking at the angiogram, how will you make out whether the vessel is on the surface or whether it is in the groove or whether it is in the interventricular septum? Can you make out by looking at the nature of the vessel, the movement of the vessel? Can you make out whether it is in the atrioventricular groove, whether it is in the interventricular septum, or whether it is on the surface of the ventricle? How do you make out? Here, of course, I have not shown an artery in the atrioventricular groove. Anyone of you, how will you make out whether a okay, I think next time I will bring three angiograms by means of which you should be able to make out whether the artery is in the atrioventricular groove, whether the artery is in the surface of the ventricle, or whether the artery is in the intraventricular septum, by looking at the movement of the arteries. So here, what is the management strategy, Saroj?
Yes, sir. Sir, I have to know whether patient is diabetic or not.
The patient is diabetic.
Yes, sir. Then, sir, I have to go for a sir, CABG.
CABG. But do you want to go for CABG, or do you like to calculate any score to decide?
Yes, sir. Yes, sir. Syntax score has to be measured.
Yes,
Sir,
syntax.
22 and 33. Sir, they are the like. Sir, if less than 22 in a patient, then sir, we may go for a. If non-diabetic, then we may go for a revascularization by PTCA.
Okay. Usually the syntax score is reasonably good one, where the score up to 22, you can recommend a interventional treatment. Score between 22 and 32, it is actually borderline, and when it is 33 and above, it is better to send the patient for a CABG. 22 to 32, there are many other factors, like as you rightly said, diabetes, and other factors will decide whether the patient can be taken up for an interventional procedure. But below 22 and below, probably it is safer and maybe worthwhile subjecting the patient for a coronary interventional treatment. The results are reasonably good. But if the patient is having a higher score, it is better that the patient goes for a CABG. Second, as she has rightly pointed out, if the patient is having diabetes, many studies, different studies have shown that the survival benefit, everything is much better with the CABG, and those patients who are diabetics having a left main, and along with the other arteries are also involved, and the score is between 22 and 32. These patients also better sent for a CABG. Below 22, I would still recommend that you can subject the patient for a interventional treatment. Okay, we'll go to the next one. What is this?
Post CABG, sir, or post intracardiac surgery.
So post CABG angiogram, and what you are saying?
This native vessel, sir. Native right coronary.
Are you sure it is native right coronary? Can you see the native right coronary there?
Yes, sir.
So if you look at here, this is the native right coronary.
Okay.
See, can you see here?
Yes, sir. Yes, sir.
This is actually graft to where? Where is the graft going?
So before the crux to the RCA.
Pre-crux into the RCA. The graft is going to pre-crux into the RCA. What are the problems of the graft intervention? What are the problems?
Depends on the which arteries or veins are used.
Oh,
Their venous is having high occlusion rate.
yeah. Understand? No. What are the problems during the procedure?
Sir, arterial grafts frequently go for spasms.
Arterial graft, okay. Arterial graft, of course, is slightly different because they are arteries. I'm speaking about the venous graft. Here, this patient has got a venous graft. So, what are the problems of venous graft interventions? And how will you circumvent the problems? Most of the times when there is a venous graft occlusion, there will be a lot of atherosclerotic and cheesy material which can actually get displaced and will go to the distal branches, resulting in occlusion of these distal branches. And this can be overcome by with the use of what? You can make sure
distal protection device.
Yes, distal protection device can be used, and distal protection device has to some extent can filter the atherosclerotic material going forwards and resulting in occlusion of the distal branches. So distal protection material, distal protection devices is a class 1A indication in patients with venous graft intervention. Now, what is the next problem?
High rate of occlusion.
High rate of occlusion. Restenosis rate is much higher in patients with venous graft angioplasty. So that's another problem. Third problem.
Reintervention is.
And that of course is because of the restenosis. Another problem is that the venous graft, if it is distended too much, they are prone for rupture. See, there is a venous graft rupture can happen if you are distending more, and hence when you are doing a intervention, actually it is better to undersize the graft which you are placing in a venous graft. Undersize the stent that you are placing in a venous graft. Usually, it is better to measure the size of the venous graft, and probably you can take a stent which is about 10% less in size compared to the venous graft. That also reduces the risk of rupture, because if the stent that you are selected is large and is equal to or more than the size of the venous graft, there is always a risk that the venous graft may rupture, and that may be catastrophic. So whenever you are doing a venous graft intervention, 2-3 precautions. One, use a distal protection device. 2, size of the stent can be slightly undercorrected than overcorrected. 3, the correct deployment is extremely important, and post dilatation may be done if necessary. And in these patients, the risk of the later restenosis rate also comes down. There are some people who believe that it is not safe to do a post dilatation in stent in venous graft stents because of the risk of rupture. So you have to be careful when you are doing a post dilatation. So 3 precautions. 1, listed post protection device. 2, undersize the stent. 3, post dilatation to be done carefully. Post dilatation has got 2 problems. 1, if it is done too much, it can cause rupture. And 2, post dilatation also can result in displacement of a lot of atherosclerotic material, which can go distally and can embolize. Of course, distal protection device mostly protects against the distal embolization. Okay, right. What is this? What is the surgery which has been done on this patient?
Glen.
Glen procedure. It's a Glen procedure. It is so superior vena cava is anastomosed to the right pulmonary.
Right pulmonary artery.
Pulmonary artery. Is there a problem here? Is there a stenosis?
No, sir.
At all, there is a mild stenosis, may not be significant because there is some degree of stenosis, but not very significant. Let's say you can see that there is some degree of
LPA, left pulmonary artery.
there is some stenosis, but not very significant. So this is a Glen procedure. What is bidirectional Glen? What is bidirectional Glen?
Sir, their superior vena cava is anastomosed end to end with the just at the MPA, sir. So that the blood will flow on both the sides, RPA as well as LPA.
What about
there is another bidirectional, bilateral bidirectional also, sir.
What is bilateral bidirectional? What about IVC?
So both superior vena cava and inferior vena cava are attached graft material, and it is connected to pulmonary artery.
Yes, and also some people also give a vent in the IVC, so that if there is any reason there is an increase in the pressure in the pulmonary arterial system, there can be an outlet which can go into the right artery. So bidirectional gland means both the superior vena cava and the inferior vena cava both can be anastomosed. Actually, superior vena cava to the right pulmonary artery and inferior vena cava is more close to the main pulmonary artery at the junction of the right pulmonary artery with main pulmonary artery. They are a little more medially so that the IVC blood can easily flow into the left pulmonary system. So this is a gland procedure. Okay, what do you find here?
Dissections.
Beg your pardon? What did you say?
So there is a spillage of the blood in
Yes.
the pericardium.
Yes.
So
There is a-
perforation, small.
There is a perforation. Yes. What is the management of perforation?
It
Prolonged
depends.
balloon occlusion.
Yeah, one is before you withdraw the balloon, you should do a test, and if there is any perforation, you reocclude. You inflate the balloon and try to reocclude. How much? What is the time duration during which you will keep the balloon inflated?
30 seconds.
30 seconds. Oh, that's nothing. No, no.
Sir, up to 10 minutes or like earlier ischemia will come.
Yeah, yeah. If the you can go up to 10 to 15 minutes, then only there will be good benefit. And some people also recommend that you can reverse the apparent dosage. And what is the what amount of apparent dosage is reversed?
For 100 units, 1 milligram of protamine has to be given.
Oh, that's right. That's the dose that you use. But what I'm asking you is that how much will be the apparent dosage that you will try to reverse? Suppose you are given, let us say you are given 10,000 units of apparent. How much will you reverse?
50%.
We'll try to get EPT at 150, sir.
No, no, you cannot do all those things because they already perforated. You can reverse 50% and keep the balloon inflated for about 10 to 15 minutes. And most of the perforations can be sealed by this procedure. But if it is a rupture of the coronary arteries, then it becomes difficult. Then you have to go for then
Covered
what is
stent.
Covered
Covered
stent.
stents.
then it's a covered stent. What is the problem of covered stent?
Sir, compromise of side branches.
So the compromise of side branches 1, 2. Restenosis rate is much higher. So two problems. So the side branch compromise, the restenosis rate is higher. So, but when a patient has got a ruptured coronary artery, then the treatment option is covered stent. Okay, good. Right. Okay. What do you find here? What do you find? This is also is a coronary angiogram which shows
There is a fistula
Fistula
yes,
between coronary
between
artery
the
and coronary sinus.
and
Coronary sinus.
there's a coronary cameral fistula, and most likely it is opening into the fistula. So the dye is immediately cleared. So most likely it must be opening into a ventricle, and the common site of coronary cameral fistula is into the which ventricle?
RV.
RV, into the RV. So this is a coronary cameral fistula into the RV. Okay, right. Okay, what is this? This you might have seen a number of times. So there should not be any problem for you to diagnose it.
A tactical.
Not a tactic coronary. Anybody who would like to come to your diagnosis?
Kawasaki.
Al Capa.
Al Capa, sir.
Al Capa. It's an Al Capa. You can see that this is the right coronary injection, and it fills the left system completely. And you can see that the left system is draining into the pulmonary artery. So you can see that it is draining into pulmonary artery. So this is a Al Capa. The right system is supplying the whole of the left system, and then you can see the it drains into the pulmonary artery. And what will be the physical finding in this type of patients? You will be able to hear a
Continuous murmur.
Continuous murmur.
Can there be patients with Al Capa without continuous murmur also? Al Capa without continuous murmur, do they how are they sick, or are they?
They will be cyanosed, sir. Very
Cyanosed?
sick.
Why are they cyanosed?
From pulmonary, the reversal of the flow from pulmonary artery. No, sir, MI will develop.
Yeah, they will develop myocardial infarction.
Yes.
In a newborn baby, if you find that the patient is in heart failure and you find QSL, lead 1, AVL, and anterior chest leads, then you should always think of the possibility of Al Capa. And Al Capa, which does not make a noise, obviously means there are very few collaterals, and they develop severe, they develop myocardial infarction, and they develop severe LV dysfunction, and unless you do something urgent, the child will not survive. What is how is the left coronary artery filled in a patient where there is no communication between the right coronary artery and left coronary artery? If there is no communication between the left coronary artery and the right coronary artery, how is it that the left coronary system gets filled? Because pulmonary artery pressure may not be sufficient enough to perfuse the coronary arteries. What is the hemodynamics?
From the Sebacean vein.
Beg your pardon?
The Sebacean vein and directly from the ventricle.
Okay, it can get directly from the ventricles, mostly in the RV. Okay, that's right. But how can the left system be filled? What will happen to these patients when they develop ischemia to the myocardium, myocardial infarction? What will happen to LV and diastolic pressure? And LV and diastolic pressure gets elevated, and that will result in pulmonary congestion, and that will progressively result in pulmonary arterial hypertension. These patients progressively develop pulmonary arterial hypertension, and once they develop pulmonary arterial hypertension, the left system can be filled from the pulmonary artery itself. So actually, with the development of pulmonary arterial hypertension, the left system can get filled. Otherwise, left system may not get filled, and that will result in myocardial infarction, and these patients quickly deteriorate. And what is the treatment for this particular condition? Treatment?
The dissection of the
Yes, you're right. Yes.
the treatment of
Oil
Al Capa,
occlusion.
sir.
Treatment.
Maybe.
What is the treatment for Al Capa?
Bypass graft coronary.
Yes.
Yes, you can ligate the artery, the left system, as it joins the pulmonary artery, and the graft could be given. Can you reimplant the coronary artery into the
Yes, sir.
aorta?
We can reimplant.
Yeah, sometimes it can be done. If the mobilization is difficult, then you can actually give a graft to the left system. But if possible, it can be re-implanted into the aorta, and that will be the most ideal thing to do. But if that is not possible, then the next best thing would be to give a graft from the aorta to the left system, and the left system can be ligated at the point where it enters the pulmonary artery. Okay, right, yes. Okay, where are the catheters? which are these catheters, and tell me where the catheter is. There are two catheters.
The pigtail catheter is from the IVC to RA to
RVM.
RV.
Which catheter? Pigtail.
Pigtail catheter.
Okay.
And sir, another is sir, I think multi-purpose catheter.
It is not multi-purpose catheter. Tell me the course of the other catheter. What is the view in which this image is taken?
RAO view.
RA view, very good. Yes, it's RA view. And where is the other catheter? Other catheter is actually a Cornan catheter. Have you heard of Cornan catheter? Have you heard of Cornan? Cornan is a French cardiologist, physiologist actually, was interested in cardiology, and he has done a lot of work in hemodynamics, and for which he received a Nobel Prize also. The catheter in his name is Cornan catheter. It is an end-hole catheter. What is the course of the second catheter? Any other views? Anybody else who would like to give a comment about the catheter position and course of the catheter? Saroj, are you sure that the pigtail catheter is going into the RV?
No, sir. I was sir little. No, sir. Actually, sir, pigtail catheter is in aorta, sir.
Yes.
It is going to LV, sir.
Yes. Whenever there is a pigtail catheter,
yeah,
most likely it must be going. It must be in the left system.
Yeah, so, and sir, Cunard catheter is from the femoral IVC to the sir RA, then RV, and then after this, sir, I think it has gone to the pulmonary artery.
No.
Huh?
It is from the pulmonary artery. Where has it gone to?
Sir, PDA or sir, no, sir. RP. Sir, from pulmonary artery, where it has gone, I can't say, sir.
No. Even the pulmonary artery may not be. Is the catheter tip moving?
Sir, is it sir like we want to LV sir like Swanganj we measure pulmonary capillary wedge?
Yeah.
It has wedged.
Yeah, it has gone to into the pulmonary arterial wedge pressure. It has gone to the pulmonary arterial wedge, and that is why the catheter tip is not moving at all.
Yes, sir. Yes,
how will you make out whether the catheter is wedged or not?
Sir, one is sir, it will not move.
Yes.
And another, sir, by doing the oximetry 100%.
Yes. Though you withdraw the blood and do the oximetry, it will be saturated blood. Yes. 3.
Its pressure will be equal to LV-EDP.
That is right, but you do not know about the LV-EDP.
Yes, sir.
The pressure pattern will
be like LA.
Yeah, what will happen to the pressure pattern? Pressure pattern in the
V will be more than the A.
All right, that's right. But what is the pressure pattern in the pulmonary artery? It is an arterial pressure pattern.
Oh yes, sir.
When it is wedged, it will become a
venous pressure. Axial pressure.
Venous pressure pattern. When in the pulmonary artery, the pressure pattern will be an arterial pressure pattern. As it wedges, it becomes a venous pressure pattern. And what will happen? The respirator, when the patient breathes, there will be a respiratory variation in the pulse wave pattern. In the pulmonary artery, the respiratory variation will not be seen, but in a patient with pulmonary artery wedge pressure, there will be a respiratory variation of the pulse wave. So there are 4 points. 1, it will be fixed when it is wedge pressure. 2, the pressure wave pattern will move from arterial to a venous pattern. 3, when you withdraw blood, it will be 100% oxygenated. And 4, the fourth one is there will be respiratory variation. As the patient breathes, there will be variation in the wedge pressure tracing, while arterial pressure tracing will not have any variation. So this is a Cournant catheter which is wedge. The other is a pigtail catheter which is going from the aorta to the left ventricle. What do you mean by contractility and how do you measure contractility? Define contractility and how do you measure contractility?
The shortening of the muscle.
Contractility definition is not short. It is the effect of contractility, but what is the definition of contractility?
Inherent property of the muscle to contract.
Yes, inherent property of the myocardium to contract. You have to add some more. What is your name? What is your name?
Benzi.
Oh, Benzi. Oh, very good. I think you are getting trained very well in KIMS. Very good. And you have to add little more sentence. It is the intrinsic property of the myocardium or the muscle to contract
at a fixed load.
Yes, very good. More correct to say is that independent of the loading conditions. Preload, afterload is not included. So contractility is the intrinsic property of the muscle to contract independent of the loading conditions. Okay. How do you measure contractility?
Don't know.
Okay. Anybody? Final years? How do you measure contractility? Contractility is measured by dP or dt. You measure the rate of rise of pressure over a unit time. That will be the measure of the contractility. dP or dt will give you the contractility of a particular myocardium. That's contractility. Okay, right. What is afterload?
Resistance against which LV has to pump.
Okay, very good. It is the afterload is the resistance against which LV has to pump the blood. It's known as the afterload, which includes even the LV outflow obstruction also is part of the afterload. Most of the in normal people, the most important what are the factors which decide the afterload? What are the components of the afterload in a normal person?
Peripheral vascular resistance.
Peripheral vascular resistance, very good.
Stroke volume.
Stroke volume, very good, yes.
So compliance of the aorta.
Very good, compliance of the aorta. Stiffness of the aorta, yes.
This much.
Then viscosity of the blood and to some extent preload also. All these contribute to the afterload. So the things which contribute, main contributions are from the peripheral resistance and the compliance of the aorta, stiffness of the aorta. Other components which I can also contribute are stroke volume, the viscosity of the blood, and even to some extent preload also. So that is afterload. You should know what is afterload. And the next one is a little more difficult. What is afterload mismatch and what is the importance? What do you mean by afterload mismatch and what is the importance? And we must give an example of an afterload mismatch. Anybody who would like to say about afterload mismatch?
Sir, in corrective valvular surgeries, when we correct the valvular level, like regurgitation lesions, when we correct, so afterload will increase acutely.
Okay, very good. In a patient with, you are right. In a patient with, especially in mitral regurgitation, when you replace the mitral valve, the patient there will be an acute increase in the afterload, and some of the patients can go for afterload mismatch. Very good. But you should describe what is afterload mismatch. Define. You are right. You will quote an example. And the simplest example is that patients with sudden rise in blood pressure may suddenly develop acute LV failure and pulmonary edema. That also is due to an afterload mismatch. The example quoted is right, but then you have to explain what is afterload mismatch. Okay, afterload mismatch. Yes. Yes. Hmm? One of the students who answered said the one classical situation where there can be an afterload mismatch.
It is the inability of ventricle to match the afterload in cases of acute changes in the pressure, acute changes in the resistance.
Very good. What is your name?
Sir Dheeraj.
Dheeraj. Okay, very good. I think that's a very correct definition. That is the ventricle is not able to function against an acute change in the resistance or pressure, while the ventricular function, inotropicity, everything remains the same. But suddenly there is a change in the resistance and ventricle is not able to pump against that ventricle. One best example is an acute rise in the systemic blood pressure, and the patient can develop acute left ventricular failure. So the afterload mismatch is the inability of the ventricle functioning at a stable level of inotropic state to maintain normal stroke volume against the altered afterload. And very often it is an acute rise in the afterload. Example, acute systolic loading of the ventricle in acute hypertension can lead to LV pump failure. When a patient develops acute rise in blood pressure, the patient can go in for acute left ventricular failure. The patient will not have any myocardial dysfunction. One of the most important things that you should know is that any patient who has developed an afterload mismatch due to an acute rise in the afterload, if you bring back the afterload to the original position, the function of the ventricle will significantly improve. So whenever there is an afterload mismatch, you should try to correct the mismatch. Best example is acute rise in systemic blood pressure. So afterload mismatch is the inability of the ventricle functioning at a stable level of inotropic state to maintain normal stroke volume against the altered afterload. So very often it is due to an acute rise in the afterload. Best example is acute systolic loading of the ventricle in acute hypertension can lead to LV pump failure without myocardial dysfunction. Afterload mismatch occurs when preload reserve is unable to compensate. Whenever there is an afterload increase, it is actually compensated by an increase in the preload. But when there is an acute increase in the afterload, preload compensation may not take place, and that is the most important reason for development of acute afterload mismatch. So acute afterload mismatch is the inability of the ventricle functioning at a stable level of inotropic state to maintain normal stroke volume against the altered afterload. What is wall stress and what are the factors which can modify wall stress? And what is the compensatory mechanism when there is an increase in the wall stress? What is wall stress, myocardial wall stress, and what are the factors which can modify wall stress?
Sir, it is the load on per unit of myocardium during systole.
Very good, excellent. What is your name?
Santosh, sir.
Very good, excellent. It is the pressure on a unit of myocardium.
No.
Okay. And what are the factors which can modify wall stress?
Sir, after load, LV chamber radius and thickness of myocardium thickness.
Very good, excellent. Wall stress, it is the load on per unit of myocardium during systole. Wall stress is modified by afterload, LV chamber radius, and heart muscle thickness H. Applying the Laplace equation, wall stress is equal to, it is directly proportional to the pressure and the radius, while it is inversely proportional to the thickness of the heart muscle. So whenever there is an increase in the wall stress, what is the compensatory mechanism? In order to make the wall stress back to normal, what is the compensatory mechanism whenever there is an increase in the wall stress?
Hypertrophy, sir.
Hypertrophy. The myocardium hypertrophy is because the thickness of the myocardium is inversely, the wall stress is inversely proportional to the thickness of the myocardium, and it is the most important and the best compensation when there is a increase in the wall stress. That is how in patients with hypertension, where there is an increase in the afterload, the heart muscle compensates by producing hypertrophy. So hypertrophy is a compensating mechanism. Okay. Now there is an electrocardiogram. Some difficulty in seeing it, but I think still you can see it. If somebody can read the electrocardiogram, what are the abnormalities in this electrocardiogram, and tell me what is the diagnosis. What is this electrocardiographic diagnosis? What is the axis?
The axis is right axis deviation. So the axis is right axis, sir.
There is right axis deviation, very good.
Left atria is enlarged.
Left atrial enlargement, very good.
Yes, sir. There is a prominent R wave in V1.
There's
with Q, with
yes.
Q also, sir.
Yes, so, QR pattern in V1.
So suprasystemic pulmonary artery hypertension, mitral stenosis, sir.
Yes. What about right atrial enlargement?
Sir, right atria also, yes, sir. Right atria also enlarged, sir.
Yes. So there is a biatrial enlargement. There is a most likely suprasystemic pulmonary artery pressure, and most right axis deviation. All put together, most likely the diagnosis. Whenever there is right ventricular hypertrophy with left atrial overload, diagnosis mitral stenosis. Because whenever there is right ventricular hypertrophy, usually the right atrium is the one which gets enlarged. But in mitral stenosis, the right ventricular hypertrophy may be associated with the left atrial enlargement. So when you get a combination of right ventricular hypertrophy with left atrial enlargement, always think of mitral stenosis. Okay, very good. This electrocardiogram. Whenever a strip is given to you, there is a rhythm strip. First thing that you should look at is whether it is a atrial rate is more than the ventricular rate, or the ventricular rate is more than the atrial rate. If the ventricular rate is more than the atrial rate, it is an abnormality in impulse formation. While if the atrial rate is more than the ventricular rate, it is an abnormality in impulse conduction. Sorry, if the ventricular rate is more than the atrial rate, it is an abnormality in impulse formation. And if there is an abnormality, if the atrial rate is more than the ventricular rate, it is an abnormality in impulse conduction. Yeah, that's right.
Here is sir, ventricular rate are more than the atrial rates. So sinus node dysfunction is possibility.
Yes.
But sir, some of the sinus beats are also conducted, sir.
Yes. Some of the in between there is a conduction. This is a conducted beat.
So, sir, this is either a sinus pause or sinus exit block, or sir Winky back at the sinus node level.
What did you say?
Sir, either sinus node dysfunction, maybe sinus pause, or sir sinus.
You cannot actually call it a sinus node dysfunction, because if you look at the, if this is a P wave, this is a P wave. What is the rate? 1, 2, 3, 4. Rate is about 75. You cannot call it as a sinus node dysfunction.
But after that, sir, the P waves is coming very late.
Here also it is like that. For example, say look at here. It is 1, 2, 3, 4. almost 5. 1, 2, 3, 4, 4.5, 5.
Yes, sir. So one of the sinus P wave is not seen in between. So 2 are seen, then 1 not seen, sir.
No, no, no. Why are you not seeing? This is one PU. This is one PU. This is another PU. PU is another PU is here. Another PU is here. I am assured it. I am giving you a clue. This is another PU. PUs are occurring regularly.
So, but AV dissociation is there, sir.
Not completely AV dissociation. You can say AV dissociation with occasional capture beats.
Yes.
This is a capture beat. This is a capture beat. This is a capture beat. So in between there is a capture beat. Okay, yes. But the definitely the atrial rate is much less than the ventricular rate. So it is an abnormality in impulse formation.
Yes.
Because the ventricular rate is more than the atrial rate. So what can be the problem? This is a narrow QRS complex.
Yes, sir.
So it is a supra ventricular focus. And when it is a narrow QRS complex supraventricular focus, what can be the possibility?
A nodal escape.
Yes, it can be from the junction. It can be from the junction with a retrograde
P waves.
No.
Retrograde conduction.
Retrograde block. There is no conduction there because this QRS complex is not generating any P wave. So this is not P waves are independent of the QRS complex, and its rate is lower, and it must be coming from the sinus node, and with intermittent capture beat. This is a capture beat. So the final diagnosis is junctional rhythm, most likely junctional tachycardia, with retrograde block and intermittent sinus capture beats. So at the appropriate time, the sinus is capturing, and the main focus is there is an abnormality in impulse formation, and most likely this is a junctional focus. Since the rate is around 100, in a junctional focus, you have to consider junctional tachycardia. So the final diagnosis is most likely junctional tachycardia, retrograde block, with occasional sinus capture beats or capture beats. Okay, we'll go to the next one. The simple one, not a difficult one.
The trifesticular block.
Why did you say trifesticular block?
So because the right bundle branch block is there.
Yes.
Right axis deviation with increased PR interval.
Yes, there is an increased PR interval. And what does the right axis deviation indicate? What is the normal axis in a patient with the right bundle branch block? Usually. What is the axis in a patient with the right
normal? It's a normal axis. Here it will be a left posterior hemi block also.
Yes. What is the normal axis in a patient with right bundle branch block?
So up to 100.
Yeah, around 90 to 100. Usually it is around 90. So when it goes beyond 100, you have to think of associated some other conduction abnormality. And so here, what is the axis?
So lead 2 is isoelectric.
Yes.
So sir, sorry, equiphase.
So axis around
160 plus 90, 150. Sir.
Yes, around near about 150. So it is a significant right axis deviation in a patient with right bundle branch block. Usually indicates associated left posterior hemi block, and on top of that, the patient is having first degree heart block also. So it is a right bundle branch block, left posterior hemi block, and the first degree heart block indicate that the third fascicle also is diseased. So it indicates trifesticular block. You're right. Very good. Yes. What does this rhythm strip indicate? What is the arrhythmia and
idioventricular rhythm, sir?
Which one?
This one, idioventricular rhythm.
Idioventricular rhythm. Very good. Yes. Accelerated idioventricular rhythm. And then what happens?
Sinus rhythm is actually some sinus beats are there. Sir.
Yes.
Last 2 beats.
Sinus beats. And from these two sinus beats, can you diagnose the condition?
So this is
Revascularized.
getting a reperfusion arrhythmia, sir.
No, it's a
Perfusion, I think.
most likely, but the patient is having what? Acute
Inferior wall MI, sir.
Inferior volume.
You can see that there is ST elevation. When the sinus beat is there, you can see there is ST elevation, which is settling down actually. And you can see that the patient is having this will lead to indicating inferior myocardial infarction, and the patient is having isorhythmic, axillary deventricular rhythm, most likely maybe due to reperfusion. It's the reperfusion error. Very good. Diagnosis.
Stereotyped QRS in V1 to V6, V5.
Yes.
So single ventricle or large VST.
So TGA is a correct TGA. It's early.
Corrected TGA, what will you expect?
Early transition is there.
No, it is not early transition. What you see here is the large equiphasic reflection V2, V3, V4. To some extent in V5 also.
Sir, it is VSD, sir. Actually, CATS.
It's what is the phenomenon known as?
CATS well phenomenon.
Huh?
CATS well phenomenon.
Cat's vascular phenomenon. Okay, right. Vascular phenomenon. It's a cat's vascular phenomenon where there's a equiphasic large diffraction seen from in the mid precordial leads, and usually it will be more than 40, near about 45. Usually indicates biventricular involvement. And what is the type of involvement of the left ventricle and right ventricle in VST? What is the type of involvement? Is it a both volume overload or both pressure overload? Or one pressure overload and one volume overload?
So RB is volume overload.
No. LV?
LV will be pressure overload.
Why did you say that? Anybody else would like to give any other opinion? Is it LV pressure overload, RV volume overload?
Pressure overload, LV volume
Eh?
Sir, in VSD we are talking, sir.
Yes.
Sir, in VSD, RV will not be like, I think, volume overload only. That will be working as a conduit only to transmit the volume, sir. But LV will be volume overload, sir.
What will happen to RV?
RV will act as a conduit only, sir, to...
Okay. So what is it overloaded?
Not exactly, sir. Pressure overload only, sir.
Okay. Yes. So in VSD, the volume of blood coming to the LV is more, and
yes,
that
sir.
happens during diastole. So there is a volume overload of the LV, and as you rightly said, it functions only as a conduit, because when the LV contracts, when the blood is through the VSD which enters the RV is contracting also, so it will be immediately ejected into the pulmonary artery. But in a patient with a VSD, large VSD, if the patient develops pulmonary arterial hypertension, then the RV will be subject for a pressure overload. So LV volume overload, if small VSD, no overload on the RV, but if the patient is developing pulmonary arterial hypertension, there will be pressure overload. So a volume overload for LV, and in large VSD, there will be pressure overload of the right ventricle. When the equiphasic deflections in V2 to V4, V3, V4, where there is a large deflections, are suggestive of cat's vascular phenomenon, and it is seen in patients with large VSD. Okay, right. Yes. What does the ECG electrocardiogram show?
So ST elevation with QS in V2 to V4.
Very good.
So this team of sir, either sir, old, sir, it is anterior wall MI or sir aneurysmal formation.
Not the aneurysm formation, it may be resolving anterior myocardial infarction.
So deep Q wave with ST elevation persisting.
It can happen. I agree with you that you can discuss, but what does the lead to show?
So lead 2-3 wave also shows slight elevation, sir.
Okay.
So it may be like it is like a wrap around LED, sir.
Very
like
good.
it's supplying the inferior wall as well as the anterior wall, sir.
Very good.
Or there is one more possibility, sir. Old infarct, which is developed collaterals and supplied by a single artery, and that is now got occluded.
Okay, right. But you can explain the ST elevation lead to, which is can be explained by a wraparound LED, and it is more seen when the LED occlusion is distal to the D1 and S1. When there's a occlusion of the LED beyond D1 and S1, and it goes into the inferior surface of the left ventricle, that can result in ST elevation in lead 2, lead 1, lead 2, and also sometimes in AVF also. That is seen here. Do you think that there is any evidence of pericarditis?
Yes, sir. PR segment is down, sir.
Yes, there is some depression of the pericardium, even in the PR segment, and there is one of the electrocardiographic indicators of pericarditis. Why it is happening? What is the mechanism? It is because of the inflammation of the atrial musculature, which can result in injury pattern, and that will result in ST depression in PR segment. And whenever you see a PR segment depression, you can always think of the possibility of associated pericarditis. So this patient had pericarditis also, right? Okay, this simple rhythm strip.
CHB, sir.
What did you say?
A complete heart block.
What is the criteria for complete heart block? 4 criteria.
Sir, PP
Intraventricular dissociation.
Yes, there's atrioventricular dissociation, but what are the criteria? Tell me what.
Regular. PP should be regular.
PP regular.
And rate should be more than ventricular rate.
Atrial rate more than the ventricular rate.
QRS should be regular.
QRR regular.
QR interval regular. Then there is no relation between P and QRS complexes.
PR interval will be going on changing. 4 criteria. 1, PR AV dissociation evidenced by PR interval going on changing. PP interval regular, RR interval regular, and P rate is more than the R rate. So these are the criteria for complete heart block. So here this is it a suppressing complete heart block or
suppressing, sir?
Suppressing.
What are the QRS complex?
What are the difference between supraventricular complete heart block and infra-ECN complete heart block?
So intra-ECN are non-stable actually. Intra-ECNs are non-stable. Supra-ECNs are a stable complete heart block.
Okay.
We can observe and
one electrocardiographically, what are the
QRS duration, sir? Duration of the QRS.
Yes. What is the difference?
More in so infra-ECN it will be widened.
Yes. Wide QRS complex in infra-ECN and narrow QRS complex in
supra-ECN.
Right. Third point.
Associated bundle branches.
Yes, if there is an associated bundle branch block, then it can be always broad. But what are the other criteria to differentiate supra-ECN from infra-ECN? What about the rate?
It will be lesser in infra-ECN.
Yes. What will be the usual rate in infra-ECN? What is the usual rate?
Less than 40.
Less than 40. About 20 to 40 is in infra-ECN and 40 to 16 supra-ECN. What is the response to exercise?
So, supra-ECN, it responds better to the atropine.
Yes. Whether they can respond better to atropine, there can be even exercise, there can be some response to exercise. So supra-Asian complete heart block has many favorable points. One, the rate is more, 40 to 60. Two, narrow QRS complex indicating that the ventricular conduction is through the normal pathway. Three, the exercise can increase there can be some increase in the exercise related heart rate increase, which can result in better cardiac output. So there are a few points which makes the supraventricular or supraventricular focus or supraventricular complete heart block hemodynamically more favorable. And also, since they can also respond to exercise, very often they remain asymptomatic, especially a congenital complete heart block, which is a supra-Asian type of a complete heart block. Many patients can actually lead a normal life without any symptoms. The problem with infra-Asian is not only the slow rate, but it is an unstable focus. And since the focus is unstable, it may suddenly stop firing, and that can result in sudden cardiac death. So patients with the infra-Asian complete heart block has got a much worse prognosis compared to supra-Asian complete heart block. Diagnosis.
Atrial fibrillation with wide QRS complexes of LBB morphology.
Yes. So it's a LBBB in a patient with atrial fibrillation. So it's important to make out that the patient is irregular. And otherwise, sometimes suddenly when you see a tachycardia with broad QRS complex, we have got a tendency to diagnose ventricular tachycardia. But here, once you see this irregularity, then and this is an LBB pattern. So the diagnosis atrial fibrillation in a patient with pre-existing left bundle branch block. Okay, what is the arrhythmia and what are the problems?
Then atrial flutter fibrillation.
Yes, atrial flutter fibrillation. Yes.
With regular heart rate means
Yes. So
there is complete heart block also.
Complete heart block, very good.
So digoxin. So hyperkalemia.
Yes, you are right. What is this wave?
So hypokalemia.
U wave, sir. Hypokalemia.
So U waves are seen very prominent.
This is a U wave. So there is hypokalemia. When can you say that U wave is prominent? What is the normal size of the U wave?
So 50% of the T wave.
What percentage?
So 50.
No. It is too much.
15, sir. Yes, sir. 150.
5 to 15%. Usually, the size of the U wave is the height of the U wave is about 5 to 15% height of the T wave. When it is more than 15%, it can be abnormal. But if you want to say definitely abnormal, it should be equal to or more than 50% of the size of the T wave. 5 to 15% is normal. More than 15%, 50% is abnormal, definitely abnormal. 15 to 50% is borderline abnormality. If you are suspecting hypokalemia, then 30% or 40% can definitely be taken as abnormal. But if you want to really diagnose an abnormality associated with U wave height, it should be equal to or more than 50% the height of the T wave. Okay, what else is there? So you have diagnosed that patient with atrial fibrillation, complete heart block, hypokalemia.
So we have to see whether digoxin toxicity present.
Yes, this patient is, you have to think of the digital toxicity. And also this patient is an LV dominant or RV dominant?
Sir, LV dominant.
LV dominant.
Mitral regurgitation.
LV dominant. So atrial fibrillation, LV dominance, you can think of the possibility of mitral regurgitation. Patient is having complete heart block, so you can think that probably the patient is on digoxin, and with hypokalemia, the patient has developed a digitalis toxicity, and that is the cause of complete heart block. So full diagnosis could be atrial flutter fibrillation, complete heart block, LV forces more dominant, maybe mitral regurgitation, patient is having hypokalemia, and in view of the complete heart block with hypokalemia, a possibility of digital toxicity also should be considered. Yes, good. What does the electrocardiogram show?
Wenkeback type 2, sir.
What did you say, Wengeback?
Type 2.
Okay, what did you say? What? Wengeback type 2? What do you mean by Wengeback type 2?
That here center will be fixed and suddenly beat will be missed.
Is it Wengeback type 2 or something else?
This is not Wenkeback phenomena, sir. PR is constant, looks like, sir.
Mobis.
The type 2 is, if you want to use the type 2, it is Mobitz type 2 block.
Secondary type 2, what he wants to say, sir.
Yeah, it's Mobitz type 2. No, it is not Mobitz type 2 block. Wrong.
We can see after the fourth
Sinus
beat.
pause, sir.
Eh?
Sinus pause.
After the fourth beat and also after eighth beat, P waves not conduct.
Okay. What is this? This is there's a notch here. There's a notch here. What does that mean?
Conducted PV.
Retrograde P wave, sir.
Yeah, it's a retrograde P wave. It's an ectopic P wave. And what is happening to that P wave?
Not conducted because it is in refractory period.
This is in the refractive period. So there is a blocked atrial ectopic. This is a blocked atrial ectopic. And when there is a blocked atrial ectopic, it is not getting conducted to the ventricle because it is during the refractive period, but it can conduct upwards into the sinus node and then reset the sinus node. And that is why there is a gap. This is because this atrial ectopic beat, which did not conduct to the ventricle because it is too early during the refractive period of the AV node, so it is not conducted to the ventricle, but it is retrogradely conducted. It went to the sinus node and has caused a resetting of the sinus node, resulting in this interval. So this is a blocked atrial ectopic. Here you can see that there is here also there is an atrial ectopic, but it has just fallen outside the refractive period, and that has resulted in a conducted beat. Here, this is also it's a atrial ectopic. It is an ectopic beat, supraventricular ectopic beat, which actually got at the correct time and got conducted. While here and here, it is too early and has resulted in a blocked atrial ectopics. It's a blocked atrial ectopics, and which is also showing one conducted atrial ectopic. Extra-chest surround must be simple for you. We have discussed it many times.
Structure of PA wave showing the cardiomegaly.
Yes, very good.
With right atrial enlargement.
Very good.
Right ventricular also enlarged and the main pulmonary artery also dilated.
Yes, don't comment about the ventricle because sometimes it is not classical for right ventricle. Right ventricular enlargement. You definitely want to say the RV is forming the apex. It should be lifted up. It will be lifted up. So here, and there should be a good acute angle between the cardiac shadow and the diaphragmatic shadow.
Right atrial enlargement is the main pulmonary artery also moves prominent. Then right pulmonary descending artery is also
yes,
dilated.
Yes. Now, whenever there is a prominent pulmonary artery segment, what are the possibilities which should cross your mind?
Pulmonary hypertension.
Pulmonary hypertension.
Pulmonary hypertension. Second,
Shunt lesion.
shunt lesion. Third,
Post-stenotic dilatation of the pulmonary.
dilatation. Fourth, idiopathic dilatation of pulmonary artery. So these are the four conditions which should cross your mind. Secondly, to pulmonary artery hypertension. Secondly, to increased flow, shunt lesion. Three, post-stenotic dilatation. And fourth, idiopathic dilatation of the pulmonary artery. So here, what may be the possibility?
Increased flow.
Shunt lesion.
Shunt lesion. Why did you say shunt lesion?
The right pulmonary artery is prominent and end on views are more than 5 into bilateral.
Yes, there are plenty of endon vessels in 1, 2, maybe 1 or 3, 4, 5, 6, lot of them. So there is plenty of endon vessels. So there is a shunt lesion, and in a patient where there is a shunt lesion and the left atrium is enlarged, what is the diagnosis? Sorry,
Yes.
right
ASD.
diagnosis? Atrium
ASD, sir.
defect.
Septal defect.
That's very good. Is it a large atrial septal defect? Small? What is the size of the atrial septal defect?
Large.
Large. Why did you say that?
RA enlargement is there.
Yes, RA enlargement is there. But you can, as I would say, the cardiac enlargement. Whenever there is a volume overload, the cardiac enlargement is the surest evidence that volume overload is significant. So in a patient with ASD, when there is a cardiac enlargement, it usually indicates ASD is significant, and hence that has resulted in a large left-right shunt. Diagnosis.
There's a narrow pedicle, sir. Sir. Mediastinum is there.
I may not use the word narrow, the normal. Okay, right, yes. What are the other abnormalities in this X-ray chest?
Sir, upper lobe vein, upper zone, the veins are.
First describe the heart. Heart on the left border of the heart.
There is a convexity.
What is this?
Aorta.
Aorta.
What is this?
Pulmonary artery.
Pulmonary artery.
Segment is prominent. What is this?
Left atrius.
Left
appendage. That's prominent. Then this is the rest of the left border of the heart. So left appendage is prominent. Pulmonary segment is prominent. Aorta is seen just normal. And anything else? Can
RA also prominent.
RA doubtful, maybe prominent 1, 2, borderline. Okay. Is there a left atrial enlargement in the by double shadow? Already we have seen a appendage is prominent, but is there any other evidence?
Not very well seen about the bronchus and the double contour.
So it's not bronchus is not well seen. If you are taking a penetrating view, then that can definitely help us to diagnose double shadow. Here it is an underpenetrated film, so it's extremely difficult. But the patient has got evidence of left atrial enlargement as evidenced by left atrial appendage is prominent in the left border of the heart. Okay, right. Yes.
A pulmonary venous hypertension present.
What are the X-ray evidence of pulmonary venous hypertension?
So prominent upper zone waves.
Yes. Redistribution of the blood upper zones. Yes, true. What is the difference between redistribution and sometimes you can see prominent upper lobe vessels in increased pulmonary blood flow. Redistribution. There's already what is the difference between upper lobe vessel prominence due to pulmonary congestion and equally prominent upper lobe and lower lobe vessels in a shunt lesion? For that matter, what are the X-ray features of increased pulmonary congestion?
Other like Kerley lines.
Kerley lines, okay, very good. What else?
Interlobar fissure will be prominent.
Yes, inner lobar fissure can be.
Diffusion may be present and bat swing appearance.
Yes. But you have to describe what are the important X-ray evidences of pulmonary venous hypertension or venous congestion. One, of course, we have thought about the upper lobe vessel prominence. 2,
Curly B lines.
Curly lines, especially B or A can be seen. B lines are more easily detectable. Okay, right. 3. 3.
Prominence of interlobar fissure or fluid in the interlobar fissure.
But that can be due to other reasons also. If there is a
pneumonia,
inflammation.
Peribronchial coughing.
Yeah, peribronchial coughing, very good. Ground glass appearance and frank pulmonary edema. So these are the features of pulmonary venous congestion. Good. The upper lobe vessel prominence, curly lines B and A. 3. Peribronchial coughing. 4. Ground glass appearance, and 5. Frank pulmonary edema. Okay, right. Yes. So what are the features this patient is having? This patient definitely is having prominent upper lobe vessels.
Redistribution is present.
Yes, there is a definite redistribution. Yes. And also,
little peribronchial coughing is present in
you can see this is a peribronchial coughing.
So curly line also seen, sir.
Yeah, curly B lines are seen. Peribronchial coughing is here. You can see another peribronchial coughing here. How do you diagnose peribronchial coughing? How do you diagnose peribronchial coughing?
So thickness of the bronchial wall.
Yes, it is because of the thickness of the bronchial wall. You will see the central air, which is dark, and that is surrounded by a thick surrounding tissue, which is actually due to edema of the tracheal bronchial mucosa. That can result in bronchial mucosa. That can result in that is the appearance of the peribronchial coughing. Peribronchial coughing in and around the bronchial tree, bronchial tube. There can be edema resulting in white patch of shadows, which you can see, and this is suggestive of peribronchial coughing. So this is a peribronchial example of peribronchial coughing. Here is another area of peribronchial coughing. I can't say any more. And you can see actually curly lines were seen, but not very clear in this one. But peribronchial coughing is clear. Upper lobe vessels are prominent. So there is evidence of pulmonary venous hypertension. And the patient is having left atrial enlargement. Patient is having pulmonary segment is prominent. All put together most likely
mitral stenosis.
Mitral stenosis, very good. Diagnosis.
Pericardial calcification.
Yes, pericardial calcification. What is the diagnosis?
Constricted pericarditis.
Oh, okay. Any other suggestions? Can this be any other calcification?
The pulmonary artery also calcified.
What is this
calcification? PDA.
It's a PDA calcification. You can see two parallel lines and there is a calcification process. This is a PDA calcification. You can see prominent right pulmonary artery. So this is a case of Eisenmenger syndrome with a very huge pulmonary artery is cut off peripherally. There is a centralization. Actually, there is a prominence of the central vessel, especially pulmonary, the main branch. The right pulmonary artery is significantly dilated, and it is in the higher the vessels are prominent and significantly dilated, whereas you go to periphery, the vessels are not clearly seen. This is suggestive of Eisenmenger syndrome and in a patient with patent ductal arteriosus. Very good. Diagnosis.
AD group calcification, sir.
And the avicular calcification, there is dense calcification. Mitral.
Mitral annular calcification.
Mitral annular calcification. Mitral annular calcification. This is a dense calcification involving the mitral wire, and most likely it is a mitral annular calcification. Diagnosis.
TGA.
John, what did you say? What is the RV? What is the apex looks like?
Apex upturn, sir. It is a top.
RV type.
RV type. And what about the pulmonary segment?
Empty, sir.
Empty. There is a bay, pulmonary bay. So, presence of a RV type of apex, which is upturned apex, and with a pulmonary bay, you should always think of the first possibility as
Of tetralogy.
And also you can see that vessels are very few. There are 1 or 2 vessels here, but there is the lung field is oligamic. This is a 3-day-old baby.
TGA.
Yes, TGA.
Agon side appearance.
Yes, there is a agon side appearance, and more importantly, in a 3-day-old baby, we expect large thymus shadow. The disappearance of thymus shadow even occurring even in intrauterine life, and
Digestion.
You must always think of a stress situation, and transposition of great arteries is one condition where the child may be born without a thymus. So the absence of that is strongly in favor of a diagnosis of transposition of great arteries. And also somebody has already made a comment that there is an agon side appearance. And if you look at the pulmonary vascularity, it will be increased in a patient with TGA. So multiple points: increased vascularity, agon side appearance, there's some degree of cardiomegaly. All put together, the patient we can diagnose it. We can make a diagnosis of transposition of great arteries. This is simple. You might have already seen it.
Calcified pericardial calcification.
Yes. Is it pericardium, or do you have a different diagnosis?
Aneurysmal calcification.
Yes. We don't jump to a conclusion. You can describe it. There is a calcification seen more towards the apex of the LV, apex of the cardiac shadow, and you like to have a what view to confirm?
Lateral.
Lateral view. If you take a lateral view, you can confirm whether it's pericardium or not. And actually, in this patient, it was actually an aneurysmal calcification following a myocardial infarction few years ago. So sometimes the myocardium also can get calcified, and that is what you are seeing in this patient. So myocardial calcification sometimes can happen following a myocardial infarction, aneurysm, and an aneurysm can get calcified. Okay, this is a cardiac catheterization data. Can somebody interpret it? Simple one, not a difficult one.
So in the oximetry, there is a step up seen at SVC to RE, high RE level.
Yes, what did you say?
Step up seen at RA.
Right, step up with the right atrium, because it is from mixed venous sample here is around 68, and from 68 it has gone to
78.
78, 84, even 84, low R is 84. So there is a oxygenated blood coming to the right atrium. So there is a left to right turn at the atrial level. Okay, right, yes. Anything else? About pressure data.
The pressure data RA and LA pressure almost same.
Same, yes. That usually indicates what?
Sir, there is a shunt, maybe
yes,
sir, non-restrictive ASD.
Large shunt at the atrial level, which has resulted in equalization of pressures between the right atrium and the
left atrium.
Left atrium, yes, very good.
And sir, there is a sir gradient between RB and sir pulmonary artery. Not much, sir. Maybe flow related.
Yes, there is a gradient between the RV and the. What about the pressure? Is the RV pressure elevated?
So 45 and just 25, sir.
Yes, RV pressure is 45 is definitely elevated. And what about the peer pressure? Is it elevated?
Now 20 is to be sir, just borderline, sir.
Yes.
Mean pulmonary artery pressure 20.
There's RV to PA 15 millimeter pressure gradient, which can be explained by the increased pulmonary. When a patient with AST with a large flow, sometimes you may be able to get a small gradient. In case of mercury, in a patient with a large left to right flow, like in ASD, and no pulmonary also detected. So this is the case of, is it a large AST or a small AST? What are the hemodynamic observations which will help you to diagnose a large AST?
Pressure equalization.
Yes, very good. Equalization of pressure between the pulmonary artery bed and the right atrium. That will help you to diagnose that there is a no resistance between the right atrium and the left atrium. So it's a large AST, 1.2.
QP by QS ratio, more than.
Beg your pardon?
QP by QS ratio more than 2.
Okay, more than 2. 3 or 2.5 or more. 2 may be borderline. 2.5 or more may also indicate a large flow. Very good, yes. What else?
Flow related gradient at RV to pulmonary artery.
Yes, flow related gradient may be
up to 25.
May indicate that there is a turbulent flow. The patient is having no pulmonary stenosis, and there is a gradient between the RV and the pulmonary artery. That may indicate that the gradient is secondary to an increased pulmonary blood flow, and that also indicates high left to right shunt. Well, of course, oximeter data also will give you the clue. So this patient is having a large shunt. How do you calculate? All right. Okay, how will you calculate the bidirectional shunt? What is the formula for bidirectional shunt? What is the formula? How will you calculate bidirectional shunt? How do you calculate bidirectional shunt? And when there's a bidirectional shunt, how do you calculate left to right shunt, right to left shunt?
So we have to measure Q effective. The Q effective has to be measured.
Yes. What is meant by Q effective? What is Q effective, and what is the formula for Q effective?
Amount of blood which is going for the oxygenation is the Q effective, sir.
Yeah,
so
that's the oxygen, the amount of blood which is oxygenated is the Q effective. Yes.
So we have to Q. So we have to minus the left to right shunts.
No, but how will you calculate the effective pulmonary blood flow? That you are not mentioned.
Yes, sir. Effective pulmonary blood
oxygen
flow,
consumption
oxygen
divided by pulmonary vein saturation minus SV saturation.
Yes, the effective pulmonary blood flow is arteriovenous oxygen difference divided by
aorta minus mixed venous.
no, wrong. It's actually the pulmonary venous blood minus
SSV.
Yes, minus pulmonary venous blood minus mixed venous sample. The oxygen difference between the venous pulmonary venous blood minus systemic venous. That will give you the effective pulmonary blood flow, which is equal to effective systemic blood. That is equal to effective systemic blood flow. Both are same. And then you calculate the left right shunt, and from that you deduct the effective pulmonary blood flow. That will give you the you calculate the pulmonary blood flow, and from that you deduct the effective pulmonary blood flow. That will give you the left right the left right shunt. Similarly, you calculate the systemic blood flow, and from that you deduct the effective pulmonary blood flow. That will give you the right left shunt. So by applying this formula, you should be able to you can calculate the effective pulmonary blood flow, effective systemic blood flow, and from that you can calculate the shunt, the left to right shunt as well as right to left shunt. So effective pulmonary blood flow is the one which you have to calculate first, and then you calculate as applying the regular formula. You apply the systemic blood flow. You also calculate the pulmonary blood flow. The pulmonary blood flow minus the effective pulmonary blood flow will be right to left shunt. Systemic blood flow minus effective systemic blood flow, which is the equal to effective pulmonary blood flow, will be the right to left shunt. Okay, right. Any other doubts? If you have got some doubts, you can ask. Otherwise, we'll stop at this level. And next class we will have if any one of you can bring a case, yes. Otherwise, I'll bring a case and we can have a case discussion next week. Any doubts? If you have got any doubt, you can ask now. Okay, if there are no doubts, I think we'll stop at this level.
Sir, do you have like calculations for these questions which you have mentioned in this slide only, sir? What is the QP/QS ratio and what is the calculated PVR and what is PVRI, sir?
Okay, we'll do that.
Because I wanted to just check the calculations, sir.
Okay, right. Okay, do that. So body surface area is 1.2 meters square. So oxygen you calculate. You can use your computer, your phone to calculate the phone calculator can be used. So let me do the calculation. You tell me the calculation. What is the pulmonary blood flow? You tell the formula. That's enough. What is the pulmonary blood flow?
For pulmonary blood flow, oxygen consumption divided by pulmonary vein saturation minus pulmonary artery saturation.
Very good. Yes.
So that hemoglobin, that 1.36 into 10. That part.
Yes. So here, what is the oxygen consumption is 190 ml divided by
hemoglobin is
what is arteriovenous oxygen difference? LA is 99 and mixed venous oxygen the
pulmonary
90. So it is 99 minus 90 equals 9. Yes. Multiplied by. So this is oxygen saturation. You have to calculate the oxygen content.
So 14 into 1.36 into 10 we have to.
Yes, 14 into 1.36 into
10.
10. Yes. Why do you want to multiply with 10?
Per liter we are
But
doing.
oxygen carrying capacity.
Why do you want to multiply with 10? You are multiplying it with 10. What do you convert it into?
Deciliter. It will be given in deciliters, sir. We need to convert.
You are converting into liters per minute.
Liters per minute.
Permanent blood flow should be liters per minute. So you convert it into 10. And then on the numerator, what will you put? Multiplied by
100.
100. Where did the 100 come from?
So to convert, because oxygen consumption is given in ml per minute, sir. So to convert into liter.
Oxygen consumption you want to convert into liter?
No, sir. Hello, saturations are given in percentage.
Yes, oxygen saturation in percentage. So 9% is by 9 by 100. And when you put 9 by 100, the 100 will go on to the numerator.
Fine.
So the formula will be 190 multiplied by 100 divided by 9 into 1.36 into 10. So that will be the
QP.
That will be the QP. And from that you can how will you calculate the systemic blood flow?
Sir, it is the oxygen consumption divided by HP into 1.36 10 into aortic saturation minus mixed venous saturation, sir.
Okay, so
mixed venous saturation we have to calculate by Flamm's formula 3 SVC plus 1 IVC divided by 4.
Okay, if the patient is exercising, in leg exercise, what is the formula to calculate the mixed venous oxygen sample?
1 SVC plus 1 IVC.
No.
Divided by 2.
No. 2 IVC plus 1.
1 9.
If the patient is not exercising and is quiet, it is 3 SVC plus 1 IVC.
Yes.
The patient is exercising, it is 2 IVC plus 1 SVC.
Yes.
Then once you calculate the systemic blood flow and then once you calculate the pulmonary blood flow, you can calculate the
QP by QS ratio.
QP by you can get the ratio, QP by QS ratio. Of course, for to calculate the QP by QS ratio, you need not calculate all these things. What can be
oxygen
the
consumption not needed, just ratio of aortic saturation minus mixed venous saturation divided by pulmonary vein saturation minus pulmonary artery saturation.
Yes. Here, what will be the QP to QS ratio? What is the QP to QS ratio in this patient? Yeah? What is the QP to QS ratio? By looking at the oximetry data.
98 minus a mixed venous saturation will measure.
No. Okay, 98 minus maybe 68. Okay, let's put it as 68. High SVC is 66, low SVC is 68. So let's put it as maybe write about or make it for okay. 68 is convenient for us. So 98 minus 68 will be
20.
30.
30.
And divided by.
So pulmonary vein minus
Pulmonary artery. That will be 9. So what will be the QP to QS ratio?
So 3.3.
3.3 is to 1. So the systemic blood flow is 1 and pulmonary blood flow is 3 times the systemic blood flow. 3.3 to 1 will be the pulmonary blood flow to systemic blood flow ratio. We can do some calculations of this hemodynamic data in one of the subsequent classes. That will be clear for you.
Yes.
Yeah. So there should not be any difficulty. But here we are just making a calculation to make it clear that pulmonary blood flow can be calculated. Pulmonary blood flow to systemic blood flow can be calculated from the oximetry data itself. You need not go for the actual calculation of the extra flow. So here the pulmonary the QP to QS is equal to QP to QS will be equal to systemic artery venous oxygen difference to the pulmonary artery venous oxygen difference. So QP to QS will be systemic artery venous oxygen difference is here 30 here to pulmonary artery venous oxygen difference is 9. So QP to QS is 3.3 to 1. So if the systemic blood flow can be taken as 1, then the pulmonary blood flow is 3.3 times the systemic blood flow. It's a large one in a patient with AS. Yes. Any other doubts? Okay, right. The next class we will have a case discussion, and following that we will have one more hemodynamic data, so that people who are juniors, first years and second years, hemodynamic data will be clear and they will know how to calculate. We'll discuss about everything: left right shunt, right left shunt, bi-directional shunt, and all those calculations, so that it will be clear for the students how to calculate the shunt without any difficulty. So next class will be a regular case discussion. Anybody who would like to bring a case? Anybody who would like to bring a case? Saroj, do you have a case to discuss?
Sir, I will try, sir. Yes, sir. Yes,
bring congenital heart disease if you have got one. Are you an cardiologist, or do you have somebody who has done pediatric MD and joined for DM cardiology? No,
sir, I have done MD medicine.
Oh, so you're an adult cardiologist. Okay, right, yes.
But I am DCH also.
You have got DCH also. Oh, I see. Oh, okay. So try to bring a case, whatever may be the case. It does not matter whether it is congenital or acquired heart disease. Does not matter. If you have got a case, you bring, and I also will bring a case. In case you could not get a case, we'll definitely have a discussion from my own case. Then there should not be any problem. Okay. Okay. Right. Good night. Thank you.
Thank you, sir. Thank you, sir.
Thank you, sir.
Okay.
So from here, I'm ending this meeting.
Okay. You can end the meeting.
Thank you, sir.
Thank you. Thank you.